it is really my pleasure to introduce my friend and professor of emeritus now of endocrinology and metabolism at the University of Pisa School of Medicine. He was the chief of diabetes and endocrinology at University of Pisa for many, many years. And I'm sure some of you, or hope most of you, if you have attended the European Association of Study of Diabetes, the EASD, he was the president for 3 years, I believe, and now he also was the chair of the European Federation of the Study of Diabetes. He's right now a professor at the Sant'Anna School of Advanced Studies, an affiliated physician for the Fondazione Toscana Gabriele. Oh my goodness, Monasterio. I apologize for my Italian that is not very good, but I've been really enjoying my friendship with Dr. Del Prato for many, many years. He's the author of 600 publications, multiple visits to the ADA, and of course, I try to attend the EASD meeting almost every year, so I get to see him. So he's going to discuss today a topic that is tremendous interest for diabetologists, and is the type 2 diabetes remission. Is it fact or is fiction? So, Stefano, please take it from here.
Yeah, Guillermo, thank you very much. Thank you very much for your very kind and warm words. That's a great pleasure, to have this opportunity to discuss with you and all the other friends that are online with us today. One of the, I think, hot topic in the field of diabetes, which is, diabetes remission, in particular remission of type 2 diabetes. This is something that have been, considered and discussed for many years. But I think nowadays we have one opportunity to really try to tackle this treatment goal for these people. So what I'm going to do with you is just to reason a little bit about what we have in terms of evidence for remission, what is remission, and what could be maybe in the near future, or what we need to keep in mind in order to try to achieve such an important goal. So these are my disclosures. I've been, of course, working with many companies, but as Guillermo already said, I've been the president of the ESD, FSD, the European Association for the Study of Diabetes, the European Diabetes Forum, and I'm currently the president of a Fondazione Minorini, which is dedicated to medical education worldwide. So let me just remind you briefly something that I'm sure you know very, very, very well. And that is the natural history, or what we consider is the natural history of type 2 diabetes. This is a visual that you probably have seen many, many times, and really try to collect all together the basic information to describe what happens in diabetes. And what happens in diabetes is that before the development of the disease, here indicated by the time 0, we have some alteration in the glucose concentration, although they are not diagnostic for diabetes, which are already associated with underneath pathophysiological mechanism. In particular, a high degree of insulin resistance, and initially a compensatory beta cell hyperfunction that try to really compensate for insulin resistance in order to maintain glucose homeostasis within some acceptable level. However, with the time passing by, beta cell function tend to decline, here indicated by this red line, and because of this inability of the beta cell function to cope anymore with insulin resistance, we have this progressive increase in fasting as well as postprandial glucose concentration that, of course, detect or define the time for the detection, for the diagnosis of diabetes, but also what we consider and what we have learned by a number of studies, in particular the UK PDS, this impairment in the glucose concentration tend to increase progressively. So due to this continuous role exerted by these two basic pathogenetic mechanisms, insulin resistance and beta cell dysfunction, we have this continuous worsening in glucose concentration. And associated with that concept is that if we try to really provide, better glycemic control, what we needed to do in order to really challenge this progressive nature of the disease is to continuous increasing and intensify the treatment in order to keep the glucose down, and by that, by reducing the risk of developing diabetes complication. Now, if you look for a moment to this picture here, you can also appreciate that there is a intrinsically associated with this view of the natural history of diabetes, something that we can consider ineluctable. So in other words, doesn't matter what we do, we need to intensify the treatment because we cannot bend the mechanism accounting for hyperglycemia. And this has been what we have been believing for the past few decades. However, we may have information that this may not necessarily be the case, or at least 100% the case, or suggesting that indeed it is possible to really change the trajectory of the glucose progression over the time. So just to highlight, what is the evidence for that, I'm going to discuss some circumstances that indeed suggest that remission is possible for type 2 diabetes. And these are, the first one is the one associated with the intensified insulin regimen when it's implemented early in the course of type 2 diabetes. Then we'll be discussing a little bit about, what is the result obtained with a lifestyle intervention. Of course, the wealth of data that we have been gathering over the past years with the bariatric surgery. So let me start off, from the intensified insulin regimen in people at the time of the diagnosis or early in the course of their disease. Now, the possibility that insulin can indeed bend to some extent the progression of diabetes has been generated by this Chinese study. As you can see here, is a study that's been published a few years ago, and you can see the population that's been recruited in this study. I'm going to show the population that is recruited in this study because these are typical type 2 diabetic individuals from Asia. And you can see here, in fact, that the BMI of these individuals are not the one that we are currently used to see in our office. The BMI, although higher for the standard of that area, of that region, was at 25 kilogram per square meter. And these people had a very poor glycemic control to start with, as indicated here by the level of the A1C, close to 10%. Now, this a total of 350 people or so have been randomized to a treatment with continuous subcutaneous insulin infusion, multiple daily insulin injection, or the traditional oral hypoglycemic agents. And what has been done in this subject was to try to attain specific glycemic goals. In particular, to try to achieve, a fasting plasma glucose concentration lower than 110 milligram per deciliter, and a 2-hour plasma glucose concentration after each meal lower than 144 milligram per deciliter. Now, once this goal had been achieved, the treatment was maintained for 2 weeks after this target were achieved, and the remission was defined as the optimum glycemic control for more than 12 months without any glucose-lowering medication. And non-remission were defined those people who had a fasting plasma glucose concentration or developing a fasting plasma glucose concentration higher than 126 milligram per deciliter, or a 2-hour post-prandial glucose concentration higher than 180. So these are very, if you want, arbitrary definition of a remission, but what is important is good glycemic control achieved for a sustained amount of time without medication in this specific case. And what has been observed in that study is shown here in this survival curve. What you can see here in green are the people that have been treated with oral agents, and in blue and red those who have been treated with insulin. Namely, in blue those with continuous subcutaneous insulin injection, and in red those with multiple daily insulin injection. You can appreciate that there were many more people retaining remission, staying and maintaining that degree of glycemic control without taking any other glucose-lowering agents as compared to what has been achieved with the oral agents. And actually, you can look at this as, half empty or half full glass, because you can also see that there was a certain number of people, even with oral agents, able to achieve the definition of remission as used in this specific case, but this was much less as compared to those that had been treated with insulin. And when you look more in details, this is what had been obtained with continuous subcutaneous insulin infusion. Almost 50% of these individuals were able to achieve remission. That was slightly higher, was significantly higher as compared to multiple daily insulin injection, and definitely higher to the percentage of people achieving the remission with oral antidiabetic agents. And the most likely explanation is that the insulin treatment early on is able to relieve the glucose toxicity exerted by hyperglycemia, and to that revitalize or rejuvenate some of the mechanism underlying the progressive nature of hyperglycemia in type 2 diabetes. The authors here, they also look into some parameters or some characteristics that may be associated with the increased chances to achieve remission. And they pointed out within this Chinese population that people achieving remission tended to be younger and tended to be more obese, if you allow me to say so, although please, again, notice what is the degree of BMI, but you can see here that those achieving remission were heavier than those who were not able to achieve remission. And of course, the time to remission was important. So the sooner you get there, the chances you have to stay there and to meet the criteria for remission. Among the different factors that have been looked at for a potential prediction of the ability to achieve remission is the underlying mechanism of hyperglycemia. And in particular, you can see here that the people who were able to achieve remission also had a greater ability to improve beta cell function. And beta cell function is indeed very important in the potential for achieving remission, which makes a lot of sense. You need to have enough beta cell to start with, and you need really to preserve those beta cells in order to increase the chances to induce a remission. Now, this is one study, but this study has been confirmed by many other studies. This is just an example. You can see here the effect of insulin treatment earlier on in terms of the remission after 3, 6, 12, 24 months. And you can see here that to some extent, this remission in some cases, at least in this study here, was maintained for almost 40-45% of the individuals. And in all these studies here, what has been pointed out as a potential mechanism associated with remission is an improvement of the typical pathophysiological mechanism accounting for hyperglycemia. And in fact, together with the remission, there was an improvement in the beta cell function, indicated here by the HOMA B, along with a significant improvement in the insulin sensitivity, as indicated here by a significant reduction in the HOMA insulin resistance. But when you put all these things together and you really try to identify what could be the best predictor for remission in people with type 2 diabetes, what it turns out is that it's not the age, it's not the gender, it's not the BMI. What is really important here, as indicated by the insulin secretion evaluation, is that the beta cell function is the strong predictor for the remission in people with type 2 diabetes. Again, let me just repeat it. This fits with the concept that, the beta cell, the functional beta cell mass, it's key in the potential to achieve and maintain sustained glycemic control and the remission definition. Of course, measuring or testing for insulin secretion is not that common. It may be not also that practical. It can be not that simple. So we may use a proxy for that. And the best proxy that you can think of is the duration of diabetes, that here was sort of eliminated by this strong effect of beta cell function. You can see here the duration of diabetes is not significant. But if you look at the whole population of people who have been treated with insulin early on in the attempt to induce remission, what it turns out is that duration of diabetes is quite a strong predictor. You can see here that the proportion of people achieving a remission is much greater in those with less than 1 year duration diabetes, a little bit less for 2 years, and so on and so forth. And when you just split the population according to people with less or more than 2 year duration of the disease, you can appreciate the big difference in terms of achieving remission. So early intensification of the treatment, early use of insulin, early achievement of sustained glycemic control is a way to really achieve remission. Although I think that you can agree with me that starting all the people that are diagnosed with insulin is not really an easy way to go. So we need to consider other potential. And of course, the other potential intervention that we can think of is the intensive lifestyle. Lifestyle is very important. It has been shown by many studies. Let me just remind you, for instance, what is the effect of specific diets in terms of inducing remission. This is a meta-analysis combining a number of trials using different kind of diet, including the Mediterranean diet and so on and so forth, and showing that irrespective of what is the absolute degree or the absolute percentage of people achieving remission, it shows that it's possible to achieve indeed that remission based on specific diet. Although we can also appreciate, it's also happens, for many other interventions, that with the time passing by, the percentage of people that remain with the remission may be becoming lower and lower. And you can see here the number of trials have been evaluated. This is the 10 trials assessing remission in 6 months, down to 3 trials assessing remission to 24 months. But allow me just to discuss with you 2 examples, which I think are potentially of great interest. The first one is what we have learned from the Look Ahead study. You know very well the Look Ahead study is a study which is very important for at least 2 basic reasons. The first one is the size of the population, more than 5,000 people with type 2 diabetes, and the follow-up, 12 years of follow-up. And you may remember that this study was designed to look at the ability of intensified modification of the lifestyle in terms of inducing glycemic control, and even more to really provide reduction in the cardiovascular risk. And you may remember as well that the primary endpoint, reduction in cardiovascular disease, unfortunately wasn't met. But yet, it's important, as I said, large number of people, long time, long follow-up, comparing people of the usual medical care plus diabetes support and education for 4 years, and here usual medical care plus intensified lifestyle intervention for 4 years. And a number of outcomes have been assessed in the Look Ahead, and among these outcomes, more recently, data have been reported in terms of remission, here defined as achieving an A1C lower than 48 millimole per molar, 6.5% at a single point time. And you can see here the frequency of people achieving this target over the year of the follow-up. And now you can see here that the in absolute term is not as close to the one that we've been discussing, for instance, with the early insulin treatment, but still it is much better than the usual lifestyle intervention by many folds, and it remains significantly higher, although it declines over the time. But still, after 12 years, there is still, a certain percentage of people who are still without any treatment and with a fasting plasma glucose concentration, or actually an A1C that is very low and is below the diagnostic criterion for diabetes itself. So the lifestyle intervention can indeed exert some effect and can provide opportunity for inducing remission. But in terms of the lifestyle modification, what I think has been the trial that really has steered the greatest interest really is the direct trial that has been carried out in Scotland. And I liked very much this trial because it's a very pragmatic one. It was not done in the academic setting, but actually it was performed with a collaboration of 49 primary practices in Scotland. This is an open label, cluster randomized trial, and the intervention was very, very, very simple, although very blunt if you want, because the intervention was, first, stopping all the glucose-lowering agent from day one, these people started for up to 3 months, or up to 5 months, a restriction in the total daily calorie, because a formula diet was provided, offering between 800 and 850 kilocalorie per day. So the study really looked at what is the effect of a limited time of intervention, although an intervention that was very drastic in terms of the total calories that have been allowed to these people. And these people are people much more similar to the one that we are used to. As you can see here, these people are not like the Chinese people that were recruited in the insulin intervention trial, because if you look at the body mass index, these are much closer to the one that you can see nowadays in our offices. BMI was 35, 34, and the BMI and the glycemic control to start with was not as bad as the one of the Chinese population that we have been looking at before, because you can see here that the average A1C to start with was in the range of 7.7, 7.5%. And no people with prior insulin treatment were recruited in this study. Again, and one way to identify those people that may have retained some of the beta cell function in their condition. So what's the result of DIRECT that I'm sure you already know very well? DIRECT, through that 3 up to 5 months of 800, 850 calorie per day, was associated with a significant reduction in the BMI. You can see here the body weight reduction, 9 kilo by the end of the first year. And remember, this is not 1 year of low-calorie diet. The low-calorie diet was just limited to those initial 3 to 5 months. That was retained, although a little bit reduced, at the end of the second year of the follow-up. And we know very well that we can reduce the body weight of our people with diabetes. We can also expect a significant metabolic impact, as shown here, for instance, in terms of the glycemic control. And you can see that by the end of the first year, there was a 0.9% reduction in A1C, which was half of it at the end of the second year. With this decline of A1C, some of the people also met the criterion for remission. And the criterion for remission used in the DIRECT is shown here. A1C less than 6.5%, at least 2 months after initial withdrawal of glucose-lowering agents. And you can see here how many of the people in the DIRECT trial were able to achieve this kind of definition. It was 45% at the end of the first month, and it was also close to 35% at the end of the second year. Now, what is the mechanism for this improvement in glycemic control to the point that we may have a sizable percentage of people achieving remission? Most likely, this is the effect of the body weight reduction, as it has been suggested by the analysis that was comparing the percentage of people achieving remission as a function of the reduction in the body weight. And you can appreciate first year, second year, the two columns, that with the increase in the amount of body weight which is lost, there is an increase in the percentage of people achieving remission. And you can appreciate here how people losing more than 15 kilograms, 86% at the end of the first year and 70% at the end of the second year, already and still remained with diabetes remission. So body weight reduction is important, but body weight reduction is not necessarily the best predictor for the ability to achieve remission. In fact, when this population have been evaluated in terms, once again, of the duration of the disease, now you can see that duration still play a major role, and most likely that duration is linked to preserve beta cell function. You can see here that in those with the less than 1 year duration of the disease, 77% were able to achieve remission, which went down to 16, 11, and 2 with the increase in the duration of the disease. So duration is very important. The DIRECT also highlighted the importance of body weight reduction. And there is no doubt that body weight reduction, is an important mechanism. And this is what we have learned from a large number of data that are being generated by bariatric surgery. Just to make a long story short, these are data from the SOS, the Swedish obesity study, which reports the percentage of people achieving remission after the first 2 years and after 15 years from the bariatric surgery. And you can see here, first of all, how effective can be bariatric surgery, because after 2 years, there was close to 70, more than 70% of the people achieving remission as compared to less than 20% in those in the control group. And after 15 years, there was still a 30% of the population that was able to achieve remission as compared to just a few percent of those in the control group. And again, let me just point it out to you that the remission here was defined as a fasting plasma glucose concentration less than 100 milligram per deciliter and not diabetic medication. Now, one thing that is important to consider here is the role of the body weight. And you can see, in fact, that the body weight may play a significant role if you do compare what you can obtain with bariatric surgery as using the Roux-en-Y gastric bypass or the sleeve gastrectomy. And you can see here that with sleeve gastrectomy, you have less remission, quite a size though, as compared to the Roux-en-Y gastric bypass, which was associated with a much greater effect in terms of a percentage of people achieving A1C lower than 6.5%. And most likely, this is explained to some extent by the difference in the ability of the two interventions to achieve a reduction in the body weight. But body weight, as I said, can be a guidance for the ability to achieve remission. But there is not a linear relationship existing between body weight reduction and percentage of people achieving remission, or the chances to achieve remission. In this study, where a number of data have been compiled together, what you can see here is the relationship existing between percentage of body weight loss and chances to achieve remission in this population of obese type 2 diabetic individuals. And there are a couple of interesting information, I believe. The first one is that in order to achieve a sustained or a reliable chance to achieve remission, you need to have at least 10-15% body weight reduction. And the other interesting thing is that once you go above a reduction in body weight of 20%, there is not very much to gain. So we have a window, which is an interesting window between 10 and 15%, which is also reminiscent of the body weight reduction that I mentioned to you with the bariatric surgery. You remember the less than 15 kilos that you can also consider similar to a 10-15% at least body weight reduction. Now, body weight reduction is important, but maybe is not the only element or the only mechanism. Let's go back once again and compare two surgical approaches for bariatric surgery, namely sleeve gastrectomy in red here, or the gastric bypass in blue. We can see here is the remission of type 2 diabetes and the percentage of people remaining with the medication, which is sort of related to that. And what you can appreciate here is the gastric bypass, as already mentioned to you before, is associated with a greater degree and a greater persistence of the remission as compared to the sleeve gastrectomy, which may be, as I already was alluding to a differential effect in terms of the total amount of weight loss. But this may not be the only explanation. In fact, when these two conditions here have been evaluated in terms of the profile of the secretion of the incretin hormones, GLP-1, GIP, glucagon, ghrelin, some differences emerge to characterize the two approaches. And you can appreciate, for instance, if you look at here, if you focus your attention on the top part of this panel here, which refers to the GLP-1 secretion, after 5 months and 1 year, you can appreciate that the GLP-1 response to an ingestion of a meal is much larger in people with a gastric bypass as compared to sleeve gastrectomy. And GLP may also play a role in terms of modulating the central nuclei associated with appetite, satiety, and so on. But GLP-1 also is an important rejuvenator of beta cell function. And in fact, when you look at the beta cell function in these individuals here, particularly after 5 weeks, or in particular, in even more after 1 year, you can appreciate that the preservation of the improvement in beta cell function is much better with the gastric bypass as compared to the sleeve gastrectomy. So the idea is that with the gastric bypass, what you do obtain is not just a restriction of the absorption of calories, but actually you have a resetting of the hormonal milieu of the incretin system, which is, summarized here. And I think this is interesting because what is postulated here is that some incretin hormones can be secreted endogenously, but to the same token, now we may have the opportunity to act on the same receptor that are modulated by gastric bypass using GLP-1 receptor agonist, dual agonist, and in the near future, also triagonist. So we can look at a condition where we have endogenous secreted peptide hormones or exogenous administered hormone receptor ligands. And I think this is important and of interest because we have data, and this is data from the SURPASS-4, looking, for instance, the effect of tirzepatide in people with type 2 diabetes, suggesting that at least with the highest dose of tirzepatide, we can have up to 37% of the people achieving more than 20% body weight loss, which you may remember is associated per se to a significant increase in the chance of achieving remission. And in support of this, we also had close to 45% of the people achieving an A1C, which is lower than 5.7%, and 5.7% is the upper limit of the normal range for the A1C levels. So I like to suggest to you that together with the circumstances that I've been discussing with you, intensified insulin regimen, intensive insulin intervention, bariatric surgery, we can also consider among these circumstances also the use of highly effective glucose and body weight lowering agents that are may be able to mimic what may be happening with bariatric surgery in terms of the change of this hormonal. And I think that this is important because it may also allow to realign the definition of remission in diabetes to the one that has been used also in other medical field. Let me just remind what is the approved, if you allow me to say so, definition for the for remission that has been the result of the discussion really involving all the major institutions in endocrinology and diabetes. The current definition reads A1C below the level currently used for initial diagnosis of diabetes, 6.5%, and remaining at that level for at least 3 months without continuation of the usual antihyperglycemic agents that apparently can be used after these initial 3 months and still will have the same kind of definition for a remission. But now, without continuation of the usual antihyperglycemic agents. Allow me to draw your attention and just to maybe a little bit provocative and that we can discuss it. Now, are we sure we have condition where we can really deem we have a condition of normal glycemia without anti-hyperglycemic treatment? Lifestyle modification, for instance. Now, lifestyle modification, in order to work, needs to be maintained because maintenance is needed, and maintenance relies on motivation. So you have two options here. Or you do improve the motivation over the time of these people, so you treat these people to some extent, or you lose your effect. And we know very well that the rate of disappointment with lifestyle modification, unfortunately, is very high. Like has been summarized by Garfield the cat, when he said, that diet is like die without a T. So that gave just an example. This is the direct. The direct really has set an incredible example of how as a limited time of a low calorie intake can be associated with significant change in body weight, improving glycemic control, and people not requiring glucose lowering medication and achieving remission. But look what happened after 5 years. Look at the number here in terms of the remission. It's almost all gone. So the only way we may have to prevent this is that these people need to be recalled back and retreated once again, or they need also to be reinforced in terms of their motivation over the time. So I would like to say they need to be continuously treated. Now, what about, for instance, the achievement that have been achieved with the look ahead? And again, same thing in the look ahead. Now, if you look here, for instance, in terms of the A1C, it looks like looking at the UK PDS. Initial improvement and then this continuous progression in terms of the A1C. Similar to what I've been showing you in one of my first slide. So I think that what is really, this is really calling for is the need to reinforce, to treat continuously people, even in terms of lifestyle modification. Now, metabolic surgery can be an example. I showed you that after 15 years, there is still a sizable percentage of people on remission without oral agents. But are they really not treated? Was just, one time point in time when the metabolic surgery really switched the condition here there? I'm not sure, because metabolic surgery, as I pointed out to you, is associated with the maintenance of changes in the hormonal milieu, not to talk about changes in the microbiota that stay there and exert their effect, their continuous therapeutic effect. And no one of us would really dare to take any person undergoing the bariatric surgery to be reoperated back in order to confirm that diabetes indeed has been in remission. So for the same token, I'd really like to suggest that to you that even with highly effective medication, we need to consider also definition of remission, although the treatment may be required to stay on. And I was already alluding to, this may also harmonize the definition of remission in diabetes with the one that has been used in other conditions. Think, for instance, of oncology. Remission, a temporary state because relapse may occur. But in that period, there are also some maintenance treatments that are kept ongoing. Or rheumatology, where the definition of remission is largely associated with the degree of the activity of the disease, particularly when we use the new biopharmacology that is used in this condition. Or as just another example, if you think about the neurology and in the case of the epilepsy is considered to be being free of a seizure, irrespective of being on or off a treatment, a pharmacological treatment. So what I'm trying to convey here is that definition of remission need to be operational, need to be linked to an outcome rather than linked to the change or the restoration to normal of the pathophysiological mechanism. In the kind of epilepsy, it's not the case. Rheumatology is the same. Oncology, most of the time, is not the same, or at least for the duration of the maintenance time. So it needs to be operational. And what could be operational in the field of diabetes? There's a number of potential that you can consider. The one I like is the one that we strive for all the time in treating people with type 2 diabetes. That is to really reduce the long-term morbidity and mortality risk. Do we have any information that remission or a definition of remission can be associated with such an improvement in the outcome or in the risk of complication? Yes, we have some initial information. Let me go back to the look ahead study. The look ahead study, 12 years follow-up, intensified intervention, lifestyle modification. I showed you before what is the relationship between the treatment and the remission, but even more here, this is the association between the risk for chronic kidney disease or the risk for a composite of cardiovascular disease in people with one or multiple visits meeting the diagnosis of or the definition of remission. And you can see here that the longer the remission, the greater the effect in terms of CKD or CVD. And this makes a lot of sense because you do reduce the exposure, the cumulative exposure to the mechanism accounting for the damage to the vasculature, micro and macrovasculature, including hyperglycemia, of course. And in line with that, our results of this very large retrospective analysis, you can see here 36,000 people, 8,000 people, 9,000 people that have been evaluated in this cohort by retrospectively analyzing the number of people achieving a remission. And here remission was defined as 2A1C level lower than 6.5%, without, in the absence of diabetes medication or bariatric surgery. And what you can see here, I think is an interesting observation, which is the time-dependent dose and effect of a remission. You can see here that people with a temporary remission or durable remission do have a reduction in the risk of microvascular and macrovascular complication. And you can see that even temporary remission can achieve a sustained effect that, of course, is slightly less than the one you can get with a durable remission. And it fits with the concept of achieving a length of time with a condition that really can have a beneficial impact in terms of the risk of complication. And another example for that is coming from bariatric surgery. These are recent data that have been published in terms of bariatric surgery. And you can see here the very hard endpoint in terms of the risk in people with diabetes, and that is survival or mortality. And here is the total population, and you can see in red those not achieving remission, and in black those achieving remission. Those achieving those with surgery and those in the control one. And you can see that doesn't matter how you do achieve remission because the curve separate. Of course, the chances to achieve remission with surgery is much larger, which accounts for the smaller confidence of interval. But I also like to point it out to you that this is a significant reduction in the risk of mortality, all-cause mortality in this population once remission is achieved. And also together with the mortality, the bariatric surgery data and remission have been also associated with a significant impact in terms of risk of complication. And I'm using here microvascular and macrovascular complication. But what I'm showing you here is the distinction between those having had a remission and surgery with the duration of the disease lower than 1 year or greater than 1 year. And you can appreciate how important is the time of intervention and how important it is to achieve remission earlier on rather than later on, because if you have a longer duration of the disease, there are much less chances to really achieve remission. So in summary, the question was type 2 diabetes remission, fact or fiction? I would like to propose to you that type 2 diabetes remission is a feasible target. We may work a little bit in terms of the definition, but what I think is important that it is something that we need and we can keep in mind, because now at the time of the diagnosis, we should also consider how to achieve remission. And considering there are multiple factors that really can contribute to that possibility, but among all these factors, what is very key is the time, is the early intervention, because that early intervention is most likely the best way to really preserve, rejuvenate, reinstall the insulin secretory capacity, which is needed in order to maintain long-term glycemic control. And also keep in mind that remission is a nice concept, but remission needs to be anchored to what we want to achieve. And what we want to achieve, even through remission, even more through remission, is to prevent complication and optimize the quality of life of people with type 2 diabetes. And with that, I will stop here. But before that, I also like to really acknowledge the collaboration and discussion with Michael Nauk and Amy Rothberg that has been part of this, what I presented to you. And I hope the paper really trying to bring all this story together is going to get out soon. We are under revision right now. And with that, thank you very much. Guillermo, back to you.
Well, thank you so much, and so great. I mean, let me ask you. I mean, they have been sending me several questions, and one of them is, what is the role of insulin resistance on remission? Should we care about that, or we just only have to concentrate on beta cell function?
Yeah, but Guillermo, I think as I showed to you, if you achieve remission, of course you need to improve, both function. But in terms of what the analysis has been performed, what really plays the major role is beta cell function. And remember that most of the people that we are considering for remission are type 2 diabetic individuals with overweight, if not frank obesity. And as I showed you repeatedly, reduction in the body weight is associated with increased chances of achieving remission, but reduction in the body weight is also associated with a greater relief in terms of insulin resistance, in terms of inflammation, and so on and so forth. So I think that all these factors plays a role, but let me put it this way. Improvement in insulin sensitivity without ability to improve the beta cell function probably is not enough. You need to have the beta cell function to really restore normal glycemia.
If there is any data on GLP-1 receptor agonists on sustainability of diabetes remission, are there any studies long term?
The recent analysis that has been recently made by Gianpaolo Fadini and published on Lancet DE, suggesting that there is some initial data for the sustainability of that achievement. But of course, these are all retrospective analyses. The best information we may have will be coming from the Surpass Early trial. The Surpass Early trial is a trial where tirzepatide has been used in people with a short duration of disease, less than 4 years, as compared to the intensive conventional therapy. So all these people were people with a type 2 diabetes, as I said, with less than 4-year duration at the time of the recruitment, only on metformin without any prior other treatment, that have been randomized and have been looking at in terms of persistence, achievement and persistence of glycemic control as indicated by A1C by comparing the two treatments. The study is planned to last 4 years, but the first primary endpoint is at 2 year. And I don't know if any of you will be attending the TTD in Barcelona, March the 12th in the morning, 8:30, because I will be presenting the data of that study that will look at the effect in the early treatment we're using tirzepatide in this specific case after the initial 2 years, and then we will have also the 4 years at the end of the study.
Yeah, and there is an interesting question. Is there a mechanistic understanding on how beta cell function recover after intervention with diet and surgery? What is the mechanism? How come the beta cells improve so much?
Oh, we know that it can improve. Bariatric surgery has been a typical example. How many people who have been on insulin, multiple glucose-lowering agents, after bariatric surgery, in a very short time, they were able to get rid of all this treatment. And this is mainly because of the cell function. So why is that? First of all, because we do not need to really get confused on what is beta cell function and beta cell mass. The concept need to be unified in the functional beta cell mass. What I'm trying to say is that in people with type 2 diabetes, the beta cell mass can be reduced, but is there for in a large proportion. What is really lost is the ability to sense and respond to glucose. It's a functional defect more than an absolute loss of beta cell. And even some beta cells may be lost due to de-differentiation. It is possible to improve in the glycemic control, particularly in the long term, to really revitalize and to rejuvenate this beta cell. So the mechanism is associated with reduced demand due to the normal glycemia, which is achieved, reduced demand due to the improvement in the insulin sensitivity, a reduction in the inflammatory response, which is associated with obesity, a reduction in the lipotoxicity mechanism, because remember that most of our type 2 diabetic patients who are overweight or obese also have plenty of circulating free fatty acid and triglyceride, which exert a lipotoxic effect. So all these elements together can really improve the function of the beta cell to the point that can be achieved normal glycemia and maintained for a certain period of time.
And another question is regarding a recent paper in Diabetologia last month or 2 months ago says that with bariatric surgery, those who achieve remission were those who have duration of diabetes less than 8 years and they were age less than 30. So
Yeah.
how important is age? And maybe those patients who were more over the age of 30 or 50, they have obesity for many, many years. So
Yeah.
that beta cell of the pancreas already exhausted. So
Yeah.
but you show some data about duration of diabetes and remission.
The duration of diabetes seems to play a role in all the conditions, all the circumstances that we have been evaluating, have been discussing. I showed that the effect of the duration of the disease in people with the treatment of insulin earlier on. There is also an effect in terms of the duration for those on lifestyle intervention. And so I think it's key. It's not duration per se, but I tend to agree with you, Guillermo. The duration of disease is a proxy of multiple conditions, in particular the insulin sensitivity and exposure to damaging factors. The longer the duration of hyperglycemia, the longer the glucotoxicity. The longer the duration of obesity, the longer the effect of the lipotoxicity and the effect of the inflammatory damage associated with that. And so that's why we need to. Let me just remind everybody what we have learned from the UK PDS. You may remember the UK PDS 16, where using the OMA beta cell assessment, it was reported at the time of the diagnosis, we already have 50% of the loss of beta cell function. 50%. In the Belfast diabetes study, which was a study that really compiled different population with different duration of the disease and different predisposition to diabetes and measuring sequentially the OMA-B, the beta cell function, it was shown very clearly that even in people predisposed, there is already a 40%, 30 to 40% loss of beta cell function, which makes a lot of sense. If you have a genetic predisposition, that genetic predisposition most likely is associated with an overall impairment in the beta cell function. And you are going to act on top of that. So when we start treating people at the time of the diagnosis, we need to consider that we are already in an advanced stage. And that's why we need to be probably a little bit more, let me allow to use the word aggressive, or just to have as a potential target, not just improving glycemic control, but improving glycemic control to the level that these people can hit down to the normal range.
And one of our faculty, Priya Velanki, has worked on this ketosis-prone type 2 diabetes. Patients who present de novo with DKA, and she has reported that about 60-70% of them are able to come off insulin and be maintained with diet alone. But if you follow with diet, 70% fail within 1 year. But metformin or DPP-4 prolonged the near normal glycemia remission for up to 2, 3, 5 years. How do you explain that metformin or DPP-4 can prolong the near normal glycemia remission with agents that do not really increase insulin secretion?
Yeah, I mean, I think metformin can do. I mean, metformin can do multiple effects, which is I think metformin is a surprise every day to some extent. We also showed in the past that metformin exerts an antioxidative effect, an antioxidant effect in the beta cell, and by reducing the accumulation of oxidative markers. So whether this is sufficient to explain that, it may be a little bit a direct effect on the level of the beta cell. It may be an effect also because of the insulin sensitizing. There's a lot of discussion about the effect of metformin on that, but that can also help. Metformin has been claimed also to have exerted some degree of anti-inflammatory effect. So it can be. DPP-4, all right, you provide more GLP-1. GLP-1 is an important physiological regulator of the beta cell health. So it may also play a role there. So, and on top of that, neither metformin nor the DPP-4 do, can I use the word squeeze the beta cell? It's not like a sulfonylurea, that when you have
Yeah.
an increased activity that also can tend to accumulate in terms of the oxidative stress generated by that activity of the beta cell. So I would assume that this is the main mechanism. Let me just also remind you the result of the ADOPT trial. In the
Yeah.
ADOPT trial, we had, people with a short duration of disease, more than 70% of them with less than 2-year duration of the disease, randomized to use of a sulfonylurea, glyburide, metformin, and rosiglitazone. And you may remember very well the data. Preservation in terms of the glycemic control much better with rosiglitazone as compared to sulfonylurea and metformin in between. And they also measure the beta cell function throughout the study. And although the glyburide was associated with this huge initial increase, but then there was a much faster decline in the loss of the beta cell function, which was much faster than the one that was observed with rosiglitazone, and with metformin once again sitting in between. So that could be the potential mechanism, I believe.
So now that you mentioned rosiglitazone, I'm going to give you the last question, and I apologize, not going to be able to take all the questions. How is insulin resistance explained in metabolic associated steatohepatitis liver disease or steatosis liver disease? How is the insulin resistance? I know you're an expert in that field.
No, you are the expert, not me. But I think, I think that in what we're looking in people with liver steatosis, with MASH, muffled and muscled, is a sort of a vicious cycle. I do believe that in the vast majority of the people with insulin resistance, that insulin resistance is an incredible predisposing factor to accumulation of lipids and fat in the liver. But once you have liver steatosis, that will generate more inflammation, and that inflammation will contribute to worsen the insulin resistance. So you end up in a sort of a vicious cycle where you need to really break it down. Otherwise, we have all the consequences that we have learned to happen, in this condition.
Well, we are almost there. Thank you so much, Stefano. I mean, it's been a pleasure and honor to have you lecturing us today on such an important topic.